Thanks, Amit, for including me in this workshop on radiology. And can you see my screen? And am I audible? Am I audible? And can you see me? See my presentation? Should I start my presentation? Can you see my screen and am I audible? I hope I'm audible and you can see my slides. Can anyone confirm that?
Yes, sir. Visible, sir.
Okay, thanks. Just waiting for the confirmation. So I'm and sorry for the delay if it has happened because I thought there is a communication gap. So I'm going to talk about the new updated histology and targeted mutation in lung cancer. As we all know, that we have moved a long way ahead from the traditional view of the lung cancer, where it was just a non-small cell carcinoma and small cell carcinoma. Now the definite histological characterization of the lung cancer is mandatory, and that is not only restricted only to the histological classification, but with the evolving genomic classification now, the further molecular subtyping of non-small cell carcinoma is also very much relevant. Hence, a tissue which when a radiologist give us this tiny, very precious tissue course, they have to move ahead with the basic histological class subtyping, which for which IHC markers are required, and followed by the molecular classification of the tumor. And there are many modalities in which we can explore the genomic profile of a tumor. So these are the various types of the specimens. which we come across, and in which we have to offer it, not only the diagnosis but complete genomic profiling. And as you can see, these tissues are very tiny, and many times it becomes a very crucial for the treatment decisions. Hence, the role of an intervention radiologist and a close interaction with them is very much relevant, because the handling of these tissue right from their retrieval is very crucial. And as a pathologist, we have to act as a guardian of these tissues so that we can provide a maximum information to the clinician. And last year, the new WHO classification of thoracic tumors was published, and in this new edition of WHO classification, there are largely there are structural changes, but there are some new sections, and especially about the molecular diagnostic assays were included, and some new entities were also introduced. I'll just briefly touch upon those. So this is in brief about the various classification of the lung tumor, right from the malignant benign epithelial tumors to the malignant epithelial tumors, in which adenocarcinomas are the most common. And it's not only the adenocarcinoma now, the further subtyping of the adenocarcinoma is also very much relevant based on the histological growth patterns. And so the WHO classification of the lung tumor, as I said, mentioned that in adenocarcinomas, we have to try to make an attempt to further sub-categorize into the further types. Squamous carcinomas, they can be keratinizing or non-keratinizing. Another two types of squamous carcinoma, it can be either basaloid or lymphoepithelioma like carcinomas. Neuroendocrine tumors and large cell carcinomas, they are the other subtypes of the tumor which we regularly encounter in the lung. Large cell carcinomas, the diagnosis should be restricted only to the resection specimen and should not be offered on the biopsies. And these are the other subtypes of the tumor. So whenever we deal with these in these cases, we have to make an attempt to give a more precise diagnosis rather than giving a non-small cell carcinoma, and to restrict the use of non-small cell carcinoma as minimum as possible in the routine practice. And how we can do that? We can do that with the use of judicious use of ISCs. So ISCs should be used in lung when you are dealing with a lung tumor, but their role should be judicious, and with the idea that we have to save the tissue for the further molecular testing, because the treatment decisions is not based only on the histological diagnosis but also on the molecular profiling. So if there's a clear-cut squamoid or glandular differentiation is present in any case, then in those situations there is no need to further do the immunohistochemistry. And but if on morphology, especially if you're not sure, so you can see that these are the very tiny tissue bits which we deal, and we have to offer a diagnosis and also the molecular subtyping. So in these situations, a limited ISC, like in this case a tumor, we are not sure whether it's squamous or adeno, but TTF1 proved it to be adenocarcinoma. So these are the few subtypes in which essentially we have to do the ISCs. In other cases you can avoid it, and the percentage rate of non-small cell carcinoma NOS should be as less as 10%. So as I mentioned earlier, the adenocarcinoma, although not is the one of the common histological subtype, but it can show the heterogeneous growth patterns, and it is important, especially in the resection specimen, to comment which type of growth pattern the tumor has. Why it is important? Because it also decides the prognosis of the tumor. So as compared to the lipidic and acinar tumor, solid and micropapillary tumors has a adverse poor prognosis. And now the new WHO classification also supports that the grading of the tumor should be based on the pattern of predominant pattern along with the degree of differentiation, and the three-tier grading system for the adenocarcinoma is proposed, in which if it is a lipidic, it will be a grade 1 tumor, but if it is a poor growth pattern, that means micropapillary is solid or complex glandular pattern. These are called as a adverse poor high grade pattern. So those are going to behave in a more aggressive fashion. Next common category of the tumor is squamous carcinoma. So in this, keratinizing, non-keratinizing the types are there. So if it is non-keratinizing, in those situations, we have to do the immunohistochemistry for the confirmation. The lymphoepithelioma-like carcinoma is the new entity which was proposed in proposed in the new WHO classification. So these tumors are EBV related and likely to show the good clinical outcomes. There's another entity which is presumed to be a subtype of poorly differentiated squamous carcinoma, is a nut carcinoma, which is characterized by a specific genetic alterations, and IST for nut confirm the diagnosis. So the sinonasal tract and the mediastinum or the hilar region is the common type of site for these tumors. Another entity which is introduced in the new WHO is a SMARC A4 deficient tumor. So these are the tumors which are undifferentiated, usually don't express any markers, but show the loss of BRG, that is the SMARC A4. So this tumor has come as a new diagnostic entity in the recent WHO classification. So these are about the primary lung tumors. Briefly about the tumors of the pleura and the mesothelial tumors are the common one, and in which mesothelioma can be epithelioid, sarcomatoid, or biphasic type. And one important thing is which is mentioned in the WHO, that there is no need to call mesothelioma as a malignant or benign, because mesothelioma itself is a malignant entity, and there is no need to add the term malignant mesothelioma in front of it. The confirmation for the mesothelioma, we need ISCs, and it need to be proven, and we have to do at least 2 mesothelioma marker and 2 carcinoma markers. So use of single marker is not recommended. So every time if you're suspecting a mesothelioma, you have to minimum do the 2 ISCs. And there are some 2 additional tests which can be used for the characterization. That is, one is the BAP1 and CDK and NJ2 fish, or the P16 homozygous dilation, that also helps to the in the confirmation of a mesothelioma and to differentiate it from the atypical mesothelial proliferation. So even if as a pathologist, if you're not certain about the diagnosis, and even especially on the core biopsies, always try and contact your radiologist. And the case which might be very challenging for you on the biopsy can be very straightforward on the radiology, especially when you're dealing with the mesothelioma. So these are the just few summary of some changes which are proposed in the new WHO classification for mesothelioma. We in a similar way as we do it for the lung adenocarcinoma, we have to mention about the various histological patterns. Cytological, there are some mesothelioma which are cytologically high grade. So it is essential now to grade the mesothelioma into low and high grade subgroups, because they have a different clinical outcomes. Sarcomatoid mesothelioma, they are clinically more aggressive as compared to the epithelioid mesothelioma, and there is some high grade tumors like pleomorphic mesothelioma. They were now clubbed along with the sarcomatoid mesothelioma. So it is essential now as a pathologist, we have to grade the mesothelioma, and for epithelioid mesothelioma, it is also recommended to mention about the growth patterns. Next group of tumors in the lung is a neuroendocrine tumors, and largely there is not a significant change in the new WHO classification for the neuroendocrine tumors, but the grouping of these tumors has now become more much better, because small cell and large cell neuroendocrine carcinoma, they are categorized as a neuroendocrine carcinoma, whereas the carcinoid tumors comes under a category of neuroendocrine tumors. So there is some attempt to make it more uniform as for the other sites. So carcinoids and atypical carcinoids, the terminology is still used in the lung, and at other side we use the neuroendocrine tumors grade 1, grade 2, and grade 3. So these in this WHO still the terminology is continued. Role of MIB1 for categorization of neuroendocrine tumor, it is it can be done, but not mandatory because it is not the diagnostic criteria. But usually the carcinoid tumors, they show a low expression for Ki67 as compared to the large cell neuroendocrine carcinoma and small cell carcinoma. They show high MB1 proliferation index, but it is not mandatory criteria for categorizing. Some new entities were also included in the neuroendocrine carcinoma, like carcinoid NOS. If you are not able to distinguish between atypical and typical, especially on the small biopsy specimen, you can use the terminology carcinoid NOS. And carcinoid tumor with elevated mitotic activity and proliferation, if the morphology is still fitting with the atypical carcinoid, you can use this terminology. In addition, for neuroendocrine tumor, also now there is a role of molecular subtyping has been come, and similar way as we see in the adenocarcinoma, maybe in future we'll see more and more further subtyping even of small cell carcinomas into the molecular subtypes. So after we deal these evaluation of your histopath report on the small biopsy specimen, we have to give a comment upon the tumor content, because that open the journey for the molecular testing. And as we know, in the lung there are multiple now genetic alterations are well known, and out of which EGFR, ALK and ROS, they are the common one, but there are in addition to them, there are multiple additional biomarkers also which we need to test, and they are not they are also recommended by NCCN guidelines to test for them in the routine diagnostic assay. And there are various platforms are also now available to test for them. These are the common modalities which are being used for testing of these genetic alteration, right from the FISH, IST, PCR, and next gene sequencing. The recommendations for testing for molecular biomarker testing in the lung is essentially to test for EGFR, ALK and ROS for in all. If you want to test beyond that, then multiplex testing is recommended, and it can be tested on any non-small cell carcinoma which is advanced stage cancer. And so another role of a good intervention radiologist comes when we are dealing with these samples about how much tissue is sufficient. So these are the various tissue requirements for these various tests which you perform. So as you can see that all these tests need a lot of tissue. So if you give us a good amount of the tissue, we can perform n number of tests, and multiplex testing using NGS can give information about a lot of these biomarkers simultaneously, but the limitation of that is it is expensive, although it is a good give lot of information, but at the same time it's relatively costly, and it need more expertise, and it takes more time, so clinicians might not be ready to wait for them. And finally, even if the patient, some of these patients who are detected for this molecular alteration, they also shows a progression, and these patients, when they come with a progressive disease, then again the role of pathologist also comes to look for the reason for the resistance, and why it is again essential, because a lot of new drugs are also available. So the clinician has many options, and as due to the availability of these various genetic alterations. So the role of pathologist in the lung cancer management has evolved to a great extent, and we have to act as a guardian of these precious samples, and a close collaboration with the radiologist is very much essential if we have to provide a comprehensive report and diagnosis which is going to help the patient and the clinician at the end. So IHC based biomarkers and NGS will become very routinely, and hopefully the cost of these tests will come down and many patients will be able to afford them. So these are the various modalities which are available in the current era to the pathologist, and but with these great new techniques, it comes a great responsibility, and the most important I can again want to emphasize is the tissue which you intervention as an intervention radiologist which you provide to us. Thank you very much, and if there are any questions, I will be happy to answer them.